It's the 28th of June, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. We're on the downside of EULAR. Thank God that's over. We put out a lot of content. I hope you've enjoyed it. If you haven't consumed any of it, I suggest you go back and start reviewing it. I'd start with the lupus panel discussion and the psoriatic arthritis panel discussion, the day 1, 2, 3, 4 daily recaps. Those are good starts. Or maybe just Artie Kavanaugh and I doing the EULAR Rheumatology Roundup. We got an all new podcast this week where I'm going to give you new information, not EULAR information. Those of you who are seeking relief from EULAR. Let's begin with some regulatory decisions that came up the last few weeks while we were actually at EULAR. One, the FDA has approved sarilumab or Kevzara for the treatment of polyarticular JIA. That's a welcome addition. Also, the FDA has approved upadacitinib or Rinvoq also for polyarticular JIA and also for pediatric psoriatic arthritis. We're talking about kids at 2 years of age or older who had an inadequate response to one or more tumor necrosis factor inhibitors because it's a JAK inhibitor, right? You got to stop or use the TNF inhibitors first before you get to a JAK. That's in line with the adult recommendations. And lastly, the FDA has also approved risankizumab, the IL-23 inhibitor, also called Skyrizi, for moderate to severe active ulcerative colitis, making it, I think, the first IL-23 inhibitor approved for both forms of inflammatory bowel disease. That's based on 2 large, well-done phase 3 trials. Another big ticket item in the news, probably not too important to you, but maybe important to your patients, was the JAMA report, very large report on the efficacy of multivitamins. Surely you must have a guess on this one. It's not hard to miss. 3 large prospective trials of multivitamin use, general multivitamin use in generally healthy adults. Over 390,000 individuals showed it did not alter mortality risk one bit. So this is like a lot of evidence that's out there that a lot of the things that patients do for themselves, especially over-the-counter use, may not always be good. There was another big report this week about too many adults with no cardiovascular risk factors are taking daily aspirin when they probably shouldn't, that the risk is higher. Well, the same thing here with the multivitamin. People take it because it's a good health thing to take a multivitamin. I take a multivitamin, and that's so that I can eat badly in between. But obviously, that doesn't seem to work in preventing disease or having a true wonderful health benefit. Do I encourage it? Yes. It's a cheap intervention. It's not going to harm anyone. And if it gets people to believe they have some control of their health, well, it's the first step of many in taking control of your health. Why not? Another drug is in development. Another IL-17 is in development. This one from Moon Lake. They made an announcement this week on their dual IL-17A and F inhibitor for use in psoriatic arthritis. They have an expanded phase 3 program that they're launching. I think it's going to be 1,500 patients in 2 very large trials with an ACR 50 endpoint at week 16. We can look forward to this. Will be a competitor to bimekizumab, who will probably get to the market a lot faster than they will. But know, if you will, that there's a lot of IL-17s in play, and we're about to now get a bimekizumab at the end of the year, maybe, if we're lucky, for psoriatic arthritis. It's approved for psoriasis, where it's doing well. And then this other one is following suit, and that might be another year or 2 away. So a lot happening with the companies and regulatory agencies in the 2 weeks we were away at EULAR. I found this interesting report about cancer risk in ankylosing spondylitis. As you know, I'm interested in cancer risk in our patients and the effect of drugs. I don't think there's much. I think it's all from the disease and inflammation. Well, in this systematic review, actually it's a literature review of over 330,000 individuals with ankylosing spondylitis showed that there was an overall higher risk, a 16%, significantly higher risk of all cancers. That's the relative risk. Interestingly, when they did it, the analysis by geography, it was higher in Asia, but not in Europe. Didn't say anything about the United States. The AS patients in this analysis were at higher risk for bone cancer, thyroid cancer, multiple myeloma, leukemia, kidney, and prostate cancer, also non-Hodgkin's lymphoma, with relative risks. The highest was for bone-related cancer, a threefold increased risk. All the other ones had about a 40 to 70% increased risk that was significant. What else do we see with cancer in our patients? Well, myelodysplasia, myelodysplastic syndrome, it's on its way to something else, is it not? Or is it an entity unto its own? Happens in a lot of our patients, does it not? This one systematic review of autoimmune disease and myelodysplasia found that amongst myelodysplasia patients, 17% have autoimmune disease. And there was no difference if you had autoimmune disease or if you didn't with regards to mortality figures. It was a large spread here, 15 to 67% risk of, I think, 5-year mortality. But the question really is, why does this relationship exist? Why do autoimmune patients, RA patients, lupus patients maybe have a slightly higher risk of myelodysplasia? It reminds me of that old cartoon, happy face, normal, the sad face, cancer, and in between is autoimmune disease. That is part of some, genetically driven, epigenetic driven, environmentally driven continuum from normal to abnormal, with cancer being the most abnormal. That clearly there's always these relationships between autoimmune disease and malignancy. So scleroderma, interesting report. Actually, this is from EULAR, abstract OP0013. I found interesting. It's an analysis of the very large USTAR cohort database, over 4,000 patients with systemic sclerosis. They found that SSA antibodies are found in 15% of scleroderma patients. I wouldn't normally even check for SSA antibodies. Maybe I will now, because this report found that it's an independent risk factor for the development of lung fibrosis and maybe more severe lung disease. So the odds ratio here is 1.24. That was a 24% higher risk of lung fibrosis in systemic sclerosis if you are SSA or Rho positive. Maybe we should be checking SSA and SSB antibodies in those patients and not necessarily for Sjogren's. Another study on systemic sclerosis looked at the cause of death. This is a large Finnish cohort study of 331 patients with systemic sclerosis, and found that out of 331, there were 91 deaths. That the 5-year survival rate was 88%, 10-year survival rate was 80%. I think that kind of jives with what I see in my years of practice. Turns out that the most common cause of death was scleroderma itself. 35 of those 91 deaths were due to scleroderma. The next most common was ILD, scleroderma-related ILD, and 13 of those 91. So that's like 1 out of 7 from ILD and 1 in 3 from scleroderma itself. Now, what is scleroderma that would kill you? Well, you figure in that blank, but that's how the physicians coded it as the cause of death. The drug that we like to keep lupus patients out of trouble is hydroxychloroquine. It's got pregnancy benefits. It's got benefits with lipids. It's got benefits on survival. It's got benefits on blood thinning. It's got benefits on diabetes. It's like, what doesn't hydroxychloroquine do? Well, this study of nearly 3,000 patients taking hydroxychloroquine, I want to say this is actually from Canada, that 584, or 1 in 6 of the patients, were hospitalized more than once for lupus. And it turns out that if you were taking inadequate doses of hydroxychloroquine, you are more likely to be hospitalized. So doses of less than 5 milligrams per kilogram per day, or doses of less than 400 milligrams per day on general, were associated with an increased risk of hospitalization for lupus, with a 4-fold or a 3.4-fold higher risk for those two markers or two cutoffs on dosing that I mentioned, less than 5 per kilogram or 400 per day. Again, it's the magic drug that benefits all in patients with lupus. My next two reports are two really kind of cool things that I think are happening that you should be aware of. One, I'm running across a number of different reports where JAK inhibitors are being used as adjunctive therapy to patients who have cancer or to patients who are taking checkpoint inhibitors. And in both, whether it was Hodgkin's or a solid tumor, or in the case of someone receiving a PD-1 or PD-L1 inhibitor, that the use of itacitinib in lung cancer and Hodgkin's disease, or with ruxolitinib with checkpoint inhibitors, better outcomes in the cancer patients. And we're not just talking about with the checkpoint inhibitors that because they're on JAK inhibitors, they didn't develop the adverse events related to checkpoint inhibitors that we see. I don't think the numbers were enough that they would have enough of an incidence that they could comment on its preventative strategy there. But they were really looking at better outcomes on cancer survival and length of survival. So is there a role for, just like the cardiologists are thinking, is there a role for inflammation control and better control of heart outcomes? Well, we know the results of those studies with methotrexate, canakinumab, et cetera. But now in cancer, might there be a role for, background therapy with the drugs that we use? In this case, the JAK inhibitors, because they're well tolerated and they're expensive, and not sure how or why those were chosen. Would patients do just as well if they were taking methotrexate or azathioprine? I think this is a further evidence for the fact that the cancer doctors shouldn't be discontinuing your drugs that you give for your patients with inflammatory arthritis or autoimmune disease when they're managing the cancer. There's really no evidence that it's going to worsen the outcomes. And I think this is a trend that we're going to see more of. JAK inhibitors and maybe other DMARD therapy or biologic therapy as adjunctive therapy in cancer control. The other ones are these drugs that got their fairly good play at EULAR, and that's these BiTEs. You can actually say, bite me and get away with it and not get slapped. These stand for bispecific T-cell engagers that basically are able to better kill B cells and lead to B cell depletion by engaging T cells. So there's a number of them that were mentioned and studied in preliminary ways at EULAR. This is a recent report of a CD19 coupled with a CD3 BiTE. The drug is called blinatumomab. It's an IV preparation given to 6 refractory RA patients who failed multiple biologics and DMARDs, led to pretty brisk and effective B and T cell depletion, coupled with a rapid decline in disease activity measures, synovitis, autoantibodies, and was overall safe. Patients had a brief rise in temperature, a brief rise in C-reactive protein levels, but no evidence of cytokine release syndrome. These are like competitors to the CAR T-cell specific therapies that can lead to B-cell depletion, of course. But remember, those are autologous, need to be prepared with the patient's own blood. These are off the shelf. These are not dependent on, these are allogeneic antibody preparations and other preparations that will be used off the shelf and will compete with this next generation of CAR T-cell therapy going forward. Again, I think this is a future cool thing that we're going to see. 2 more reports. One that's going to just make you feel good about you. These are always the best kinds of literature that reaffirm that what I'm doing is perfectly fine, and that is I use methotrexate with no fear of worsening of interstitial lung disease. That's a special kind of stupid in my mind. Methotrexate causes an acute hypersensitivity pneumonitis, which does not look like interstitial lung disease at all or behave like it. And we've talked about this here before. This is an analysis from JAMA this week that says that patients with dermatomyositis have, based on literature reports, up to a 23% risk of developing interstitial lung disease. And this particular study looked at 315 dermatomyositis patients taking a number of different immunomodulators, including methotrexate, as their first-line treatment. So about a third of the patients received methotrexate compared to 64% who did not. Both groups had an equal number of ILD events, roughly 17 with methotrexate, 16% without methotrexate, thus no significant increased risk of ILD when you're taking methotrexate for dermatomyositis. And this is just one more bit of evidence that you can provide to your pulmonary colleagues who don't seem to want to recognize this literature. Lastly, we reported on this use of SGLT2 inhibitors in autoimmune disease and lupus at past ACR and EULAR meetings. This finally made it into publication with JAMA, drawing from 31,000 patients with, I think, lupus and diabetes. They did a propensity-matched pairs cohort analysis of 1,500, 1,700 plus on SGLT2 inhibitors, and those that were not, 3,500 patients. It was a 2-to-1 match. The patients were 57 years old, 85% women. Taking an SGLT2 inhibitor, if you had lupus and you also had diabetes, number one, lowered your risk of lupus nephritis by 45%. Number two, lowered your risk of dialysis by 61%, lowered your risk of transplant by 86%, lowered your risk of future heart failure by 35%, and lowered all-cause mortality by 65%. You've probably seen the trend. SGLT2 inhibitors and GLP-1 agonists being used in patients without diabetes to better manage outcomes in heart and heart failure patients and in patients with chronic CKD, bad CKD. Mark my words, we're going to be seeing the same drugs being used to better manage outcomes in RA, in lupus, and gout, and Lord knows what else going forward. So I think in the future we'll be seeing combined, if you will, combination therapy with a biologic or targeted synthetic along with these diabetes drugs that have these tremendous all-cause mortality benefits and then also end organ benefits. I think this is a cool thing. Hopefully you agree. That's it for this week on the podcast. Hope you enjoyed it. Go to the website to check out these citations and more. Next week is the 4th of July, Independence Day here in America. Room Now staff is on vacation. I'll be chasing them around to see if I can get them to do some work. But we will be doing the best of reporting next week, including next week's podcast. I hope you enjoyed it. We'll be back in 2 weeks. Take care.